Oh, sorry if this is not. Let's see here.
So, and then, yeah, because then the rain goes live. Yeah, no, obviously.
I'm going to give everyone just another minute or so before we start to go ahead and sign on.
Yeah, the one yesterday, they like take a little bit of time, so I can send them to you when they come out.
So I just take them over there. I usually just have to wait until they send my bill.
All right, good afternoon, everyone. And on behalf of the ACCP Transplant PRNs Programming Committee, welcome to our 15th and our last webinar of 2023. My name is Helen Slice, and I am a solid organ transplant clinical pharmacy specialist from University Health in San Antonio. And it is my pleasure to moderate today's webinar entitled Role of SGLT2 Inhibitors and GLP-1 Receptor Agonists in Kidney Transplantation. We are honored to have Anesti Al-Masri serve as our webinar presenter today. Dr. Anesti Al-Masri received her PharmD from the University of Illinois at Chicago, completed her PGY1 pharmacy practice residency at University of Michigan, did her PGY2 solid organ transplant residency at University of Illinois at Chicago. She is now a clinical pharmacist and clinical assistant professor at University of Illinois at Chicago. In a moment, we will get started with our webinar, but first, here are quick notes. For our audience members, please ensure that your microphone remains muted for the duration of today's presentation. The mute button is in the lower left-hand corner of your screen. If at any point during the presentation you have a question for the speaker, please submit your question by using the functionality at the bottom of your screen. Please send your questions directly to me, the moderator of today's webinar, to minimize possible interruptions. We will take questions at the completion of the presentation. Today's webinar will be posted on the ACCP Transplant YouTube channel. If you experience any technical difficulties during the webinar that are not fixed by logging out and refreshing the connection, please make the moderator aware through the chat functionality. Attendance will be taken during the webinar, and an email with CE instructions will be sent out to that email used in registering for the webinar. Now, without further ado, let's begin our webinar.
Thanks for the intro, Helen. So I'm going to go ahead and get started, talk to you guys a little bit about SGLT2 inhibitors and GLP-1 receptor agonists in kidney transplant recipients. So before I get started, Jamie Vinkin is a consultant for Trevena. Otherwise, there are no financial disclosures. This is the accreditation and joint providership statement for Rush University, so please read through that. And then I have a lot of abbreviations, a lot of which I'm sure you're familiar with, but this slide is here for reference. So today we'll be discussing the risk factors and prevalence of cardiovascular disease in kidney transplant recipients with or without diabetes in the United States. We'll talk a little bit about SGLT2 inhibitors and GLP-1 receptor agonists and their current place in therapy for cardiovascular disease, end-stage kidney disease, and diabetes. And then we'll dive into some of the literature on the use of SGLT2 inhibitors and GLP-1 receptor agonists, specifically in the kidney transplant population. So in 2020, a total of about over 20,000 people received a kidney transplant in the United States. And diabetes is one of the leading causes of end-stage kidney disease in the US. Patients with diabetes make up the highest percentage of those on the waiting list for a kidney transplant. After transplant, unfortunately, this problem does not go away, and post-transplant diabetes mellitus is one of the most common complications after transplant. We'll often hear the terms new onset diabetes mellitus and post-transplant diabetes used interchangeably. NODAT refers to the development of diabetes post-transplant in patients who were previously non-diabetic. This terminology assumes that diabetes was excluded prior to kidney transplant, but does not factor in undiagnosed or unrecognized diabetes prior to the kidney transplant. In 2013, there was an international consensus of transplant nephrologists, clinical scientists, endocrinologists, and surgeons that favored the term post-transplant diabetes. This is a more inclusive term for diabetes, which simply includes newly diagnosed diabetes in the post-transplant setting, irrespective of timing or whether it's present but undetected prior to transplantation or not. This definition does exclude transient post-transplantation hyperglycemia, and post-transplant diabetes should be applied in the setting of newly diagnosed diabetes, and type 2 diabetes will refer to those diagnosed prior to transplant. The criteria for PTDM is defined by the 88 criteria for type 2 diabetes. There's a large incidence range of PTDM recorded in studies, and that ranges between 10 to 40%. There are numerous risk factors associated with PTDM, including our immunosuppression medications. So our corticosteroids are well known to cause hyperglycemia and insulin resistance. Our calcineurin inhibitors also increase the risk of developing PTDM, with the risk being higher in tacrolimus compared to cyclosporin. Calcineurin inhibitors do diminish B-cell proliferation and insulin gene transcription. Our mTOR inhibitors are also associated with PTDM, and it's thought that it causes PTDM through effects on insulin signal transduction. A history of rejection episodes can also put our patient at risk of PTDM, especially those treated with high-dose corticosteroids. Chronic inflammation is also a risk factor. This includes the inflammatory response after transplant. Infections such as HCV or CMV and obesity can all contribute to PTDM. And then, of course, traditional risk factors also contribute to PTDM. This includes age, obesity, family history of diabetes, being of African American or Hispanic race, pre-transplant metabolic syndrome, insulin resistance, having prediabetes, and having a sedentary lifestyle. So that brings us to our first question. So MA is a 30-year-old Caucasian male with a history of lupus nephritis who is status post-deceased donor kidney transplant in September of 2020. He had a recent acute cellular rejection treated with methylprednisolone.
My audio hasn't been working.
Treated recently with methylprednisolone 1.5 grams IV. He's maintained on tacrolimus, mycophenolic acid, and prednisone. His height and weight are listed, and his BMI is 35. So which of the following factors puts MA at a higher risk of PTDM? And there's more than one answer, so you can go ahead and put those in the chat, I guess. So ethnicity, obesity, his recent rejection history, or his maintenance immunosuppression. Yeah, great. Thanks for answering, everyone. So MA has a BMI of over 30, so that puts him at a risk of PTDM, so BMI over 30, obesity. His recent rejection history, he was treated with high-dose corticosteroids, and then he's maintained on tacrolimus and prednisone, which will put him at a higher risk. He is Caucasian, so that does not alone put him at a higher risk for PTDM. So great. Thanks for answering, everyone. So why do we care so much about diabetes, and why do I have this whole lecture on these agents? So diabetes is the highest cause of end-stage kidney disease and a leading risk factor for the development of cardiovascular disease. And cardiovascular disease is the #1 cause of death in kidney transplant recipients. So looking at kidney transplant recipients from 1996 to 2014, the #1 cause of death was cardiovascular disease, which made up about 25% of death. This is compared to the general population in the United States, where it made up about 20% of deaths. These are some of the modifiable risk factors for cardiovascular disease: diabetes, obesity defined as a BMI over 30, chronic kidney disease and end-stage kidney disease, smoking, hypertension, and hyperlipidemia. Many of these factors are intertwined. Obesity may increase the risk of developing diabetes and hypertension, so it's really difficult to talk about one of these factors without talking about another. However, today I'll be focusing on the management of diabetes and how we can optimize diabetes management to reduce morbidity and mortality associated with cardiovascular disease, and talk about agents that help us manage glycemic control, but also multiple risk factors for cardiovascular disease. So while our calcineurin inhibitors may cause beta cell dysfunction, the vast majority of our kidney transplant recipients present with type 2 diabetes or PTDM that mimics type 2 diabetes, and we treat it like type 2 diabetes. So for that reason, I'll be focusing on the management of type 2 diabetes. We have lots of available guidelines for the management of diabetes. Today, I'll be focusing on the KDIGO guidelines as well as the ADA guidelines. So the KDIGO 2022 guidelines stated that for patients with diabetes and chronic kidney disease, that they should be treated with a comprehensive strategy to reduce the risk of kidney progression and cardiovascular disease. So focusing more on a holistic approach and not just medication management. That included diet, smoking cessation, exercise, and weight loss. They recommended as first-line drug therapy as an SGLT2 inhibitor, initiated at an eGFR greater than 20, and then continued until dialysis or transplant, and then the second first-line drug therapy being metformin. They commented that GLP-1 receptor agonists can be started if needed to achieve greater glycemic controls. The KDIGO guidelines do make a note, though, that these agents have not been adequately studied in kidney transplant recipients, so their recommendations to use SGLT2 inhibitors does not apply to transplant recipients. And then we have the new American Diabetes Association 2023 guidelines. In 2022, the guidelines recommended GLP-1 receptor agonists and SGLT2 inhibitor use, and recommended an individualized approach for the management of diabetes, but still stated that metformin should usually be used as first-line therapy. The 2023 have a strong emphasis on cardiovascular disease and risk management, supporting higher weight loss, broad considerations of social determinants of health. So they state for patients with type 2 diabetes and established or high-risk cardiovascular disease, heart failure, or CKD, treatment should include agents that reduce cardiorenal risks. It's important to note that the cardiorenal effects of these medications are not class effects, so the choice of medication is important, and that is why my slide is so busy and I have every single medication listed out for you. The ADA also makes note that weight management is an impactful component of glucose lowering strategy for type 2 diabetes. That brings me to our second question. You can put your answers in the chat again. True or false, patient comorbidities must be taken into consideration when choosing a first-line agent for glucose lowering. Yeah, seeing a bunch of A's. So that is true. So we want to be able to lower patients' A1C while also kind of targeting some of those other cardio or renal effects. So I'm going to go ahead and get started and start talking about our GLP-1 receptor agonists. These agents are agonists of human GLP-1 receptor and augment glucose-dependent insulin secretion, inhibit glucagon release, and slows gastric emptying. So we see its main effect, which is glucose lowering, by stimulating the glucose-dependent insulin release from the pancreatic islet cells, and we see a reduction in A1C. Average reduction in A1C is about 0.8 to 1.6%. GLP-1 receptor agonists can also lead to beta cell protection. GLP-1 receptor agonists also have a cardiac protective effect and work by increased myocardial contractility, decrease glucose uptake, increase endothelial function, decrease arterial stiffness. They have a renal protective effect by increasing sodium excretion and increasing diuresis. And then GLP-1 receptor agonists have also been shown to lead to weight loss, which is one of the reasons we've been seeing it so much in the news. So they work by decreasing appetite, increased satiety, and slower gastric emptying. Of course, no medication doesn't come without risk. So there is a black box warning for thyroid C-cell tumors in rats. So it's contraindicated in patients with a personal or family history of medullary thyroid carcinoma or multiple endocrine neoplasia syndrome type 2. So patients do need to be counseled on that. The most common adverse reactions are nausea, diarrhea, vomiting, and abdominal pain. GI upset is a particular concern for our patients maintained on antimetabolites. Many patients may already have difficult to manage diarrhea, vomiting, or nausea, and may not be able to tolerate these agents. The risk for dehydration with nausea, vomiting, and diarrhea may also lead to hypoperfusion of the kidney transplant. It's also a concern to keep in mind when starting these agents if nausea and diarrhea is profound. GLP-1 receptor agonists may also cause gastroparesis, so that's something to keep in mind for a lot of our patients who may have had long-standing diabetes prior to the kidney transplant and suffer from gastroparesis already. And then pancreatitis has been reported in clinical trials, so we also have to be aware of this, especially for our patients maintained on azathioprine. I have listed here available GLP-1 receptor agonists with shown cardiovascular benefits. You may notice some of our older drugs, such as lixisenatide and exenatide, are not shown here, and that's because while they do provide glycemic control, they've not shown to have significant cardiovascular benefit. Of note, these agents are injections given either daily or weekly. The agents are started at a lower dose in order to reduce GI symptoms, and they do not provide effective glycemic control at these low starting doses, so additional titration is required. For example, if we take a look at the semaglutide dosing, it started at 0.25 milligrams once a week subcutaneously for 4 weeks, and then can be up titrated to 0.5 milligrams once weekly, and then maybe up titrated from there every 4 weeks. GI side effects are typically transient. They're mild to moderate in severity and mainly occur during initiation and up titration of these agents. Of note, Saxenda and Wegovy are the two agents here that are also FDA approved for weight loss and are given at higher doses. Oral semaglutide may be used for diabetes, but has not been shown to reduce the risk of major adverse cardiovascular events. I know we've all either given or had to sit through lots of journal clubs with these agents, so I will not bore you, but I wanted to highlight 3 landmark trials: the Rewind, Leader, and Sustain 6 trials. Of note, transplant recipients were not included in these trials. These trials had similar inclusion criteria. These were patients with type 2 diabetes who were 50 or older and either had established cardiovascular disease or risk factors for cardiovascular disease. Dulaglutide, liraglutide, and semaglutide all showed a reduction in 3-point major cardiovascular event outcomes when compared to placebo and had favorable secondary kidney endpoints as well. That leads me to the next question. Before starting a patient on a GLP-1 receptor agonist, you must consider which of the following: a personal history of thyroid cancer, family history of medullary thyroid cancer is not a contraindication. B, the willingness to do daily or weekly subcutaneous injections. C, appropriate follow-up for dose titration, D, urinary tract infection, or E, B and C, so willingness to do subcutaneous injections and appropriate follow-up for dose titration. Yeah, I'm seeing a lot of E's. So that is correct. For A, we do have to take in consideration family history of these cancers. B is correct because it is a subcutaneous injection, and a lot of patients might not like that. They do need to have dose titrations in order to see the glycemic effects. And then urinary tract infection history does not have to do so much with GLP-1s, and we'll get into that with SGLT2 inhibitors. So jumping into sodium glucose cotransferter 2 inhibitors, they work by inhibiting the SGLT2 protein, which is located on the proximal convoluted tubule of the nephron. And the SGLT2 protein is responsible for approximately 90% of filtered glucose. We see a lot of benefits with SGLT2 inhibitors. SGLT2 inhibitors have beneficial effects on renal and cardiovascular systems by reducing plasma volume, blood pressure, body weight, inflammation, and oxidative stress. We also see a reduction in A1C. It is a bit modest. It's a 0.5 to 0.6 reduction. And then we can see an increased serum magnesium with SGLT2 inhibitors. It is modest, a 0.08 to 0.2 MEQ per liter in individuals without chronic kidney disease. It does so by many mechanisms, but one proposed mechanism is the increased glucagon concentrations observed during SGLT2 administration, which can cause increased MAG reabsorption, as glucagon has been implicated in increased MAG homeostasis. SGLT2 inhibitors have amazing benefits, and we would love to use them in all of our transplant recipients, but they're not without their adverse effects. An extra consideration needs to be placed for our transplant recipients. SGLT2 inhibitor-induced glucosuria may provide a substrate for bacteria and fungi growth and increase the risk of urogenital infections, including potentially life-threatening four-near gangrene. Infection clearly raises additional concern for patients with kidney transplant on immunosuppression who are at increased risk of bacterial and fungal infections, particularly earlier in the post-transplant period due to the risk of leukopenia. UTIs already present a significant challenge in patients with kidney transplant as the most common infectious complication. Even without the use of SGLT2 inhibitors, approximately a quarter of transplant recipients develop a urinary tract infection within the first year of transplant. Reports of euglycemic ketoacidosis have underscored the importance of SGLT2 inhibitor avoidance in those with type 1 diabetes, as well as during episodes of illness. Patients with kidney transplant are already at an increased risk of diabetic ketoacidosis, which has been associated with increased mortality. So for that reason, SGLT2 inhibitors should not be initiated as monotherapy for patients with extremely elevated A1Cs. SGLT2 inhibitors may cause volume depletion, which puts our patients at risk of hypoperfusion of the transplant and acute kidney injury. And bone fractures are also a risk in our patient population given the increased risk of fracture with corticosteroid use. I've listed here the SGLT2 inhibitors and details as a reference. Unlike glucagon-like receptor agonists, there are renal dose adjustments and cutoffs to the use for these agents. And as mentioned before, the benefit is not a class effect, and the shown benefits is listed here as well. So canagliflozin and empagliflozin can be used for cardiovascular disease, heart failure, and CKD, dapagliflozin for heart failure and CKD, and ertugliflozin for heart failure. Since 2015, sequential randomized control trials have demonstrated the efficacy of SGLT2 inhibitors improving both kidney and cardiovascular outcomes in patients with diabetic kidney disease, non-diabetic, proteinuric kidney disease, heart failure with and without the presence of diabetes. So these are some of the major trials I will review. Again, I will go through them more quickly so that we have time to go through the trials that we have in our kidney transplant recipients. So for canagliflozin, here I'm including the CANVAS and the CREDENCE trial. Canvas looked at 3-point MACE, and Credence was looking at renal endpoints. These trials found that in patients with type 2 diabetes, when compared to placebo, those on canagliflozin had a lower risk of kidney failure and cardiovascular events. Of note for Credence, there was an acute initial dip in eGFR of greater than 10% was observed in about 45% of patients treated with canagliflozin versus just 21% of those with placebo. However, long-term eGFR trajectories and kidney safety profiles were similar regardless of the magnitude of the initial dip in eGFR after canagliflozin initiation. For empagliflozin, we have the EMPA-REG trial, which included patients with type 2 diabetes who are at risk of cardiovascular disease. But our EMPEROR-reduced trial was looking at patients with heart failure with or without diabetes. These trials found a reduced incidence of 3-point MACE and cardiovascular death or hospitalization with heart failure for empagliflozin compared to placebo. Again, in the EMPA-REG, we saw after about 4 weeks, 28% of empagliflozin-treated participants versus just 13% of those who received placebo experienced an acute dip in eGFR of greater than 10%. This did resolve by 12 weeks, and long-term eGFR trajectories and safety outcomes, including AKI, were similar regardless of the initial dip. So now with the EMPEROR-reduced, we're seeing trials that show benefit for these medications, even for patients without type 2 diabetes. That brings me to dapagliflozin. So there were 3 major trials for dapagliflozin. These trials looked at cardiovascular events, kidney failure, and heart failure. DECLARE-TIMI 58 looked at patients with type 2 diabetes with established risk factors for cardiovascular disease. When 3-point MACE was looked at alone, there was no significant reduction in events, which emphasize our prior discussion that benefits that we talk about today are not class effects. DAPA-CKD and DAPA-HF, similar to the EMPEROR-reduced, included patients with or without type 2 diabetes, and we saw a reduction in kidney failure and cardiovascular events. Of note again for dapagliflozin in the DAPA-HF trials, in the first 2 weeks, we saw an average of 4 mils per minute per meter squared decline in eGFR that began to uptrend thereafter and did not lead to long-term effects on eGFR. That brings me to my next question. Cardiovascular protection is a class effect for both SGLT2 inhibitors and GLP-1 receptor agonists for patients with and without diabetes. True or false? Great. As we've discussed already, these medications don't exhibit a class effect, so we need to be very particular in which medication we're choosing. So we talked about GLP-1 receptor agonists and SGLT2 inhibitors in the general population, and I'll get into the literature in a second, but I just wanted to bring up some considerations before we get into the literature for patients with solid organ transplants. For our GLP-1 receptor agonist, we need to think about the nausea, vomiting, and diarrhea, especially for those on antimetabolites, any history of pancreatitis, and then the risk of gastroparesis, especially again for our patients with long-standing diabetes. For SGLT2 inhibitors, we have to think about whether or not a patient has a ureteral stent, which is a soft hollow tube that is placed temporarily in the ureter in order to keep the ureter open and maintain proper drainage of urine until the surgical connection between the transplanted ureter and the bladder heals, which is an increased risk factor for urinary tract infections. We need to also think about the increased UTI and genital infections, especially our patients on chronic immunosuppression, thinking about volume depletion and acute kidney injury, and then thinking about that initial decrease in eGFR that we see with some of these agents when started. Again, these early declines or dips were typically observed at 2 to 4 weeks after initiation of SGLT2 inhibitors, with subsequent partial recovery of eGFR curve by week 12. So let's get into the literature in solid organ transplant recipients. It's only apt that I start with Dr. Soisa's study since she's here moderating with us today. So this is a single center retrospective review of 118 adult transplant recipients. Majority of those patients were kidney transplant recipients, followed by liver. These were adult solid organ transplant recipients with either pre-existing type 2 diabetes or PTDM, and they had to be on a GLP-1 receptor for greater than 3 months. Majority of patients were on dulaglutide, liraglutide, and semaglutide, and majority were maintained on TAC, MPA, and PRED. The median time to initiation of GLP-1 was about 3 years. 73% of these patients were Hispanic. The baseline mean eGFR was 55 and baseline A1C was 8%. When looking at the primary outcome of hemoglobin A1C and fasting blood glucose, there was a significant reduction in both A1C and fasting blood glucose when looking at the time from initiation to the nadir from 3 to 12 months. Also found a significant reduction in body weight, BMI, and eGFR. 2 patients had to discontinue the medication due to nausea vomiting. This study was limited in that it had short-term follow-up, and the safety data did rely on provider documentation. Next, I have some ATC abstracts that I want to go through. Hyman and colleagues presented at ATC in 2022. This was a single center retrospective review of 90 adult solid organ transplant recipients with either type 2 diabetes or PTDM. Majority were kidney transplant recipients. Majority were on liraglutide, dulaglutide, and semaglutide. 87% were maintained on an antimetabolite. And again, most patients were initiated on a GLP-1 receptor agonist 3 years after transplant. The mean A1C at baseline was 7.8%. Primary outcome was again looking at A1C. This was at 3 months and 12 months. And while they saw a reduction in A1C, this was not statistically significant. Body weight, BMI, and total daily insulin dose, however, were all statistically significant. Only two patients cited gastrointestinal adverse effects as the reason for discontinuation. Kukla and colleagues presented a single center retrospective review of 17 solid organ transplant recipients. Majority were kidney transplant, majority maintained on liraglutide, and majority on TAC, MPA, and PRED. Median time to initiation of GLP was about 160 months. The median eGFR at time of initiation was 53 and the median A1C was 7.7%. There is no description of endpoint timing, but we did see they did find a reduction in A1C, body weight, and insulin requirements, and 2 patients had to discontinue due to GI side effects. And then finally, Singh and colleagues presented a single center retrospective review of 88 adult solid organ transplant recipients with diabetes. Majority were kidney transplant recipients. They were actually looking at liraglutide versus dulaglutide. And then we have the immunosuppression here. Median eGFR was 47 for the liraglutide group and 42 for the dulaglutide group, and average A1C was 7.5%. They did not have any information stated on when the GLP-1 receptor agonist was started. The results here, though, are at 24 months. So for weight, BMI, and total insulin requirements, they found a larger reduction for patients who are maintained on dulaglutide when compared to liraglutide, and an increased reduction in A1C for those maintained on dulaglutide. So the literature on the use of GLP-1 receptor agonists in kidney transplant recipients was limited to retrospective studies without controls. The effects on A1C and weight and adverse events were comparable to the general patient population. However, there were no studies that evaluated the effects on cardiovascular outcomes. Now we'll be jumping into the SGLT2 inhibitor literature review in solid organ transplants. So Halden and colleagues conducted a single center prospective double-blind review on kidney transplant recipients. I'm not used to saying the word prospective with transplant. They included transplants that were patients who received a kidney transplant that were farther than 1 year with PTDM. They had to have stable renal function and their eGFR had to be greater than 30. They also had to be on stable immunosuppression. So I think these strict inclusion criteria are important to keep in mind when we discuss the outcomes. Patients either received empagliflozin 10 milligrams or placebo. Majority were maintained on TAC, MPA, and PRED, and the median time to initiation was 3 years. The median eGFR was 59, and the median A1C was 6.9%. The primary endpoint was actually pre-specified as change in the weighted mean glucose estimated with continuous glucose monitoring. However, the primary endpoint was not possible to analyze due to technical error. So looking at their secondary outcomes, A1C and weight, we saw a significant reduction in both A1C and weight, although quite modest, but important to keep in mind that the median A1C at the start of the study was 6.9%. Blood pressure and kidney, they did not find any significant difference between empagliflozin patients and placebo patients. Of note, for eGFR, they did find there was a decrease during the first 8 weeks for patients maintained on empagliflozin, but those stabilized by 6 months. Thong and colleagues conducted a single-center retrospective review of kidney transplant recipients with type 2 diabetes or PTDM. Again, stricter criteria, they had to have absence of AKI for the last 30 days and freedom from any UTIs in the last 6 months. The average eGFR was 66.7 and mean A1C was 7.7%. Majority of patients were maintained on empagliflozin followed by canagliflozin, and SGLT2 choice was based on insurance approval. Majority maintained on TAC, MPA, and PRED, and the median time to initiation was a little less than a year. Looking at the primary endpoint, they found a significant reduction in weight when comparing a significant reduction in weight from the beginning to when they got the results, which we do not have. They did not state when their results were at. They did not find a significant reduction in total insulin or A1C, however. They did have a significant increase in magnesium concentration, very modest, of 0.13. 5 patients had to discontinue, 7 patients had to discontinue due to UTIs. Next, we have Lim and colleagues. This was a multi-center retrospective review of kidney transplant recipients in South Korea. This is one of the larger studies that I have presented today. So it included about 2,000 patients. They were comparing patients who were on an SGLT2 inhibitor to those who were not, and they were matched for mean A1C and metformin usage. They did exclude patients with a pancreas transplant and those who were maintained on SGLT2 inhibitor for less than 90 days. Majority of these patients were maintained on empagliflozin, followed by dapagliflozin. There is no statistical significant difference in the proportion of steroid and tacrolimus usage. However, of note, the mean TAC trough was higher in the SGLT2 inhibitor users. eGFR at 3 months post-transplant, they had a mean of 66.9 and a mean A1C at 3 months was 7.3%. Of note, these patients were matched for A1C and metformin usage. However, there was a significant difference in baseline BMI and percentage of deceased donor. Looking at our primary outcome, which was the composite outcome of all-cause mortality, death-censored graft failure, or serum creatinine doubling with significant serum creatinine doubling. This was significantly lower in patients maintained on an SGLT2 inhibitor. The SGLT2 inhibitor group also had a lower risk of primary composite outcome than the control group in a multivariate and propensity score matched models. Of note, a minority of the SGLT2 inhibitor users showed an acute eGFR dip of 10% during the first month, but the eGFR recovered thereafter.
Oh, where'd it go?
The next study that I want to talk about is an ATC abstract poster. So Selznick and colleagues conducted a single center retrospective review of patients with post-transplant diabetes. who were on an SGLT2 inhibitor for greater than 3 months. Majority were liver transplant recipients, followed by kidney transplant recipients. And median time to initiation was about 3 years. There's no comments on immunosuppression or which SGLT2 inhibitor was used. Their endpoints were looking at the nadir between 3 to 12 months, and they found a significant reduction in A1C and fasting blood glucose. Next, Brockmeyer and colleagues conducted a retrospective multi-center review of kidney transplant recipients. They included kidney transplant recipients who were on an SGLT2 inhibitor. Median time to initiation was 28 months. Mean eGFR at the time of initiation was 68. Looking at primary outcomes of A1C at 3 months and 12 months, they did find a significant reduction, although modest. They also did find an initial decline of eGFR by 3 months, which resolved by 12 months. And then finally, Mahmoud and colleagues in 2020 conducted a retrospective review. They were looking at patients on an SGLT2 inhibitor or a GLP-1, and then controlled those and matched those to patients for age, BMI, type of donor, immunosuppression, post-transplant duration, and type of diabetes. They included patients with kidney transplant with a diabetes, those that received an SGLT2 inhibitor or GLP-1 receptor for at least 3 months. They had to be at least 3 months from transplant, and they had to have stable renal function with an eGFR greater than 25. There was no comment on immunosuppression. 98 patients received an SGLT2 inhibitor and 41 received a GLP-1 receptor agonist. A1C was higher in both study groups at baseline compared to control, 8% for the SGLT2 inhibitor and GLP-1 receptor agonist group versus 7.2 in the control. Follow-up data was recorded for 1 year. They found a significant reduction in A1C for SGLT2 inhibitors and for GLP-1 receptor agonists. Again, modest, just 0.4% respectively. There was a significant reduction in BMI. And there was, looking at our secondary outcomes, eGFR, there was a tendency for better estimated for eGFR towards the end of the year in both study groups, but it was not statistically significant. There was a dip in eGFR observed in kidney transplant recipients on SGLT2 inhibitors at 1 and 3 months. So for SGLT2 inhibitors, the majority of studies reported were at least a 1-year duration between transplant and initiation of SGLT2 inhibitor. Most follow-up periods were less than 1 year. The effects on A1C and eGFR were comparable to the general population. The most reported adverse effects was UTI, and rates seem to be similar to the general population as well, but should be used cautiously with known risk factors predisposing conditions for UTI, as patients with a history or recurrent UTIs were excluded from the majority of these studies. It's also important to note, most of these studies had strict inclusion criteria again, including strict eGFR cutoffs, and most patients had to have stable eGFR before initiation. That brings me to the next question. When considering the initiation of SGLT2 inhibitors in a kidney transplant recipient, which of the following considerations should be made? Thinking about patient history of UTIs, A1C, since SGLT2 inhibitors only benefit patients with diabetes. We have to think about the presence of a ureteral stent, or D, both A and C, history of UTIs and presence of ureteral stent. Great, getting a lot of Ds. So as mentioned before, SGLT2 inhibitors do have benefits for patients with heart failure and CKD as well, even without type 2 diabetes. I think there's still a lot of unanswered questions. We still don't know what the best time to start GLP-1 receptor agonists and SGLT2 inhibitors, and when to resume these agents, especially if they were prescribed prior to transplant. Most of the studies in the kidney transplant recipients were started at least 1 year for SGLT2 inhibitors and farther out for GLP-1 receptor agonists as well. For our SGLT2 inhibitors, we also have to think about whether a patient still has their ureteral stent in, and potentially the magnesium benefit as well. I know sometimes magnesium can be very difficult to control in these patients. And then for a GLP-1 receptor agonist, we also have to think about concomitant medications that may cause nausea, vomiting, and diarrhea in our patients with gastroparesis. So as mentioned, diabetes is the leading cause of cardiovascular disease, and PTDM is a common occurrence for kidney transplant recipients. Both GLP-1 receptor agonists and SGLT2 inhibitors are recommended as first line for patients with diabetes who are high risk for CV events and CKD. Most of the studies for GLP-1 receptor agonists and SGLT2 inhibitors that have been studied in transplant recipients have been small, single-center studies. There are many considerations before starting these agents, including ureteral stent placement, UTI history, and nausea and vomiting. Some supplemental resources, and I wanted to thank Drs. Lindley Heinrich and Maya Kampara for helping with this slideshow as well. And with that, I'm so happy to take any questions.
Thank you so much for that informative presentation. We will now begin the question portion of today's webinar. So your first question is focused on med access. So what issues have you seen in your clinical practice with obtaining these drugs for patients?
I'm a baby pharmacist, but obviously with the GLP-1 receptor agonists, there have been shortages. And one of the biggest issues and one of the reasons we haven't been prescribing these agents is not prescribing, but a delay in prescription is due to the need for a prior authorization for a lot of these patients. And with SGLT2 inhibitors, I've noticed it's been a little bit easier since the approval for heart failure, but can still run into issues and high costs even if they are approved with insurance. So it's a great point, and I didn't even get into that on this presentation, but definitely a barrier to starting.
So in your clinical practice, how do you approach diabetes management in the first 3 months post-transplant with SGLT2 inhibitors and GLP-1 receptor agonists, as opposed to patients who are much further out post-transplant?
Yeah, I think we've talked about it here at UIC, and we want to start trying GLP-1 receptor agonists earlier on. I know a lot of centers have had a lot of success with it, especially if patients aren't feeling nauseous from the Myfortic or Cellcept. Again, it's just a question of getting it approved when we're already working on so many medications at the time of discharge. And then for SGLT2 inhibitors, we typically will not start it in those first 3 months, just given the acute dip in AKI and the increased risk for urinary tract infections, and all of our patients have a ureteral stent after transplant, so we avoid it in initial phase. For patients who are farther out, one barrier that we have right now is just up titration of GLP-1 receptor agonists. So we can start it, but we are just trying to figure out who will manage it and who will be able to follow up patients with that up titration.
Are there any recognized drug-drug interactions and recommendations for increased monitoring in our solid organ transplant patients when starting a GLP-1 receptor agonist? And this is more so thinking about that gastroparesis effect from these agents and potentially impacting absorption.
Yeah, I know some people will, most of these medications are given once weekly. Helen, I don't know if you want to comment as well, since you have a lot of experience with this. I know some people may give it in the middle of the day, or the GLP in the middle of the day, to help avoid some of those interactions, but again, they're longer acting, so I'm not sure if you want to comment, Helen.
I'm happy to comment on that as well. So our center is actually looking at this right now, looking to see how does this end up impacting immunosuppression and specifically tacrolimus levels with our patients. And so our preliminary results are so far showing that it's not impacting it. And so as of right now, we're kind of continuing as is, but there's not really much evidence specifically looking at any interactions with or any like pharmacodynamic effects of impacting that absorption. Other than I think there's one case series of like 5 patients and they solely looked at just tacrolimus levels. All right, so next question. It says, from our center's anesthesia team is recommending holding weekly GLP-1 receptor agonists for 1 week prior to procedure and daily agents 2 days before procedures requiring any type of sedation, given the risk of aspiration with gastric emptying time delay. Have you seen this occur and how are you handling this at your own center?
I've not seen this. I do not believe that our center has any requirements for holding like that. I don't know. Yeah, I'm so sorry. I have not seen that occur at our center, so can't comment on that.
Okay, next question is, why are there certain agents?
No, don't do it. Moral of the story.
Why are certain agents with SGLT2 inhibitors and GLP-1 receptor agonists found to have more benefits than others? And that
That's
it's less effect.
Yeah, that's a great question. I wasn't able to find an answer to that, and why there's such a difference. But it's out there and it's just something that we have to consider, but I haven't been able to find any literature supporting why certain agents and some not.
All right, next question. If you could please comment about the post-marketing warning about intestinal blockage with Ozempic use, and potential transplant implications with that.
The post-marketing what? I'm sorry, Helen, could you repeat it?
Oh, yes, sorry about that. Post-marketing warning about intestinal blockage with Ozempic.
So I think the way that we're handling it is just keeping in mind the gastroparesis that may occur. So any patients where that is a concern, we'd be avoiding it. But otherwise, I haven't really seen that happen yet. So it's just something to keep in mind and consider with patients if you know they have a long-standing history of gastroparesis.
Sounds good. So it looks like that is all the questions so far. If you have any other questions, feel free to reach out to Dr. El-Masri with her email here on the slide. Other than that, we'll go ahead and conclude today's webinar.
Thanks, Helen.